Hi, this is Mrs. White, and today we are going to start discussing shock. This is part 1 of shock. This is the pathophysiology. We do have several learning objectives to this module. You can pause and read them here, but in general, we want to basically learn about hypermetabolism, hypoperfusion, inflammation, the different stages of shock and what it does to the body, organ dysfunction, the different types of shock, medical management, different medications that would be used, the importance of nutritional support, and the psychosocial support. Okay, so you can tell this is pretty important because I've devoted an entire slide to one sentence. So hypoperfusion is a concept in nursing, just like pain's a concept and some of the other concepts that we've been learning about. So hypoperfusion. Basically, at its base, it is a shortage of oxygen and glucose at the cellular level. So lack of oxygen and glucose. There are several different categories of shock, but the bottom line is this. There is a shortage of oxygen and glucose at the cellular level. Another thing about shock, though, is because of what it is, honestly, this is one area that we as nurses can make a difference. We can notice the changes that occur because of this lack of tissue perfusion. So it's not only an important concept for your testing and your NCLEX, but in your practice throughout your career. Going back to the lack of oxygen and glucose, hyperperfusion leads to hypermetabolism and inflammation. If we look back at the pathophysiology of hypermetabolism and inflammation, they serve a purpose. They serve to allow the body to respond to injury and invasion, but they can also be very damaging. So too much of something is a bad thing. It's one of the things I've taught you from the beginning. So as we go through and we learn about shock, I want you to keep thinking about the decrease in tissue perfusion, the lack of oxygen and glucose at the cellular level, what it triggers, why it does what it does, and how the nurse can help. At its core, shock is a form of fight or flight. It's the release of adrenaline or epinephrine. It is not something that the body can actually control by thinking about it, though there are some things that cause it to happen, but this is part of the autonomic nervous system. So remember, the autonomic nervous system is fight or flight, which is the sympathetic nervous system, and then the parasympathetic nervous system is the rest and digest. Basically, this allows the body to maintain homeostasis. The sympathetic nervous system responds quickly to stress. The parasympathetic nervous system is much slower. The sympathetic nervous system is an accelerator, while the parasympathetic nervous system maintains the idling speed of the internal environment. Epinephrine is a catecholamine that's produced by the adrenal glands and is secreted when the sympathetic nervous system is stimulated. Under stress, it is physiologically responsible for maintaining blood pressure and cardiac output, keeping the airways open, raising the blood sugar levels. This is because of the different receptors that are acted upon by adrenaline. It helps control hemorrhage by constricting blood vessels and prolongs the effects of any kind of local anesthesia. So when adrenaline is released, it will cause different things to happen. These things are hypermetabolism. I want you to think about back to your anatomy and physiology and the different receptors. So alpha 1 causes vasoconstriction, basically shunting to the core to preserve the vital organs. Beta 1 is the one that is affecting the heart, so it increases the stroke volume. and the heart rate, which increases cardiac output. And beta 2 is a bronchodilator, really allows more oxygen to be picked up. I want you to go review these if you don't have a good grasp on them: alpha, beta 1, and beta 2. All right, so we're going to move on to this little slide here. Basically, it shows us the role of glucose and oxygen in energy production. So when we have hyperperfusion, I want you to understand it doesn't mean that there's none, but what it means is there's not enough for what the body needs. Our body is usually in aerobic metabolism, but we do have a plan B. So we can, as human beings, go into anaerobic metabolism, but this is a crummy and rather ineffective way of making oxygen and glucose into energy. So aerobic metabolism is basically 19 times more effective than anaerobic metabolism. So for example, for 1 molecule of glucose, when we're in aerobic metabolism, we can make 38 ATPs. When we are in anaerobic metabolism, that plan B, 1 mole of glucose, so 1 glucose molecule can only make 2 ATP. So if you do that math, it leads you to the aerobic metabolism being 19 times more efficient. To think of it in another way, want to compare that to that of a car in gas mileage. So imagine you had a car out in your driveway and it got 38 miles to the gallon. You'd be happy. You'd keep it around. Be a wonderful car. However, let's say you also had a car that only gets 2 miles to the gallon. That cannot sustain any sort of trip to the grocery store. It's completely ineffective, and you would get rid of that car as fast as you could. So this is sort of the same with the body. We need to be in aerobic metabolism, and if we are only making 2 ATP for every glucose molecule, well, that's not something that sustains us. And even worse than that, there's a waste product that's created called lactic acid when we're in anaerobic metabolism. You may have some experience with aerobic or anaerobic metabolism yourself. Imagine if you've ever done a workout and you end up with that pain in your legs. You feel the burn in your legs, and it takes a couple days for the pain to go away. Well, that's actually due to a localized buildup of lactic acid. It makes you feel sore. In general, the liver is what takes the lactic acid and converts it back into bicarb and provides the buffering. So that's your own familiarity with it, which is on a very small scale. When we are actually in anaerobic metabolism for the body, it's on a larger scale, so more lactic acid created. And that lactic acid drops our pH, decreases our bicarb, and leads to metabolic acidosis, which will lead to death. So to recap, the toxic end product of anaerobic metabolism is lactic acid. The liver converts lactic acid into glucose and glycogen, but during shock, because of hypoperfusion, it's really difficult to circulate the blood from the cells to the liver for the waste removal, and therefore the pH continues to fall, and the acidosis becomes more and more severe. All right, the next thing I want to talk about is, pardon me while I try and get this thing doing what it's supposed to do, is the Bohr effect. Basically, this is a principle that I hope you can understand, because it will help you understand why we need to get the person out of anaerobic metabolism basically as fast as possible. So acidosis decreases the oxygen binding to hemoglobin, but increases the oxygen release at the cellular level. So basically it holds on to the oxygen very loosely. This is why we can give 100% oxygen at a rate and a volume which is sufficient, and people still don't survive shock. It's because they're acidotic. We need to get them out of anaerobic metabolism. Now, the other side of that is alkalosis, which alkalosis is not part of shock, overall, not metabolic anyways. But that causes increased oxygen binding, but decreases the release at the cellular level, so it holds it tightly. So the overall theme here is that blood pH affects the strength with which oxygen binds to hemoglobin. When we are in lactic acidosis and shock states, there is a decreased affinity for oxygen to bind to the hemoglobin, and then it breaks it easily. So remember, pH abnormalities can be very deadly. Even if your patient's on a ventilator at 100% oxygen, the cells will remain in anaerobic oxygenation and lactic acid will continue to increase. Even maximally supplied hemoglobin will not be able to properly deliver oxygen to the cells. Remember, without adequate oxygen and glucose, the cells can't perform their functions and they will shut down and die. All right, so the next concept that I want to review with you all is hypermetabolism. This is basically an adrenaline rush, if you were to put it in layman's terms. So basically the sympathetic nervous system is activated, and we know what that result is. It's increased heart rate, increased stroke volume, increased cardiac output, and vasoconstriction. Mind you, this hypermetabolism is related to the shock state. The sympathetic nervous system also releases adrenaline and cortisol simultaneously. So these also ramp up your metabolism, right? So cortisol gives us sugar. This is why our folks who are in a shock state are generally in a hyperglycemic state. Even if they're not diabetic, it's because the body is making more glucose available because it recognizes that there is not enough. So the cortisol and the glucagons. The other part of hypermetabolism, again, is the alpha-1. So alpha-1 increases the blood pressure, the heart rate, respiratory rate, and our systemic vascular resistance, right? So that's the vasoconstriction to increase the blood pressure. You have to bring ourselves back and take a reminder of what's a blood pressure, right? It's the force of contraction against the arterial wall. So by increasing vasoconstriction, it narrows the tube to hopefully allow better pressure against the arterial wall. Another thing to look at is the sodium balance. In a shock state, aldosterone is released, and aldosterone retains the salt. And remember that water follows salt. So this is to help take care of a volume issue. So if we had our labs of a patient who is starting to go into shock, we would see them potentially with hyperglycemia and increased sodium. So the response to shock can also cause more metabolic problems. So just remember that our increased heart rate, blood pressure, respiratory rate actually require more oxygen and glucose. So the cells are already in short supply. Therefore, it's the response to shock that causes increased demands, which in turn leads to more anaerobic respiration and decreasing pH. And decreasing pH makes it more difficult for oxygen to bind. This is the vicious cycle of shock. The sympathetic nervous system is often called the first responder to shock. So what happens is we have a drop in blood pressure. Now, this drop in blood pressure in the initial stages of shock is actually pretty much imperceptible to us as nurses, right? It's dropping. We have baroreceptors in the carotid sinus and the aortic arch. They are very sensitive to these pressure drops. And what they do is they then stimulate the sympathetic nervous system. So they are looking for decreased pressure or decreased volume. It activates the sympathetic nervous system. And then that causes the release of epinephrine and norepinephrine. So epinephrine makes up about 90% of the hormones that are released by the adrenal medulla. Remember, that's the fight or flight mediator we just talked about. Causes vasoconstriction and decreased blood flow to tissues that are not needed in the emergency situations like the GI tract. It causes increased blood flow to those that are considered important to survival, like the cardiac and skeletal muscles, and increases the blood sugar levels and our sodium, so the previous slide we just talked about. Basically, it's the sympathetic nervous system is the attempt to overcome the hypoperfusion and restore the blood pressure to its normal volume and rate. The kidneys also have a role in shock. They're a secondary responder. They take a little bit longer. And this is a good time to go back and review your anatomy and physiology if you're just not sure what the RAS system was. So that's renin, angiotensin, and aldosterone. So the kidneys are prompted to release renin, which converts angiotensin 1 to angiotensin 2. So remember, that's a very potent vasoconstrictor, which works on tone. And that also we have a release of aldosterone from the adrenal cortex, which results in the sodium retention, which also results in water retention. So that works on volume. And remember, our increased sodium results in the release of antidiuretic hormones. So the body senses my salt level is too high. I want to retain even more urine. So antidiuretic hormone or vasopressin is the natural form of that, which, if it's working, will cause a decrease in urine output. Remember, in the hope of retaining those fluids. The next important concept that we need to discuss for shock is the cytokine regulations, inflammation, and basically the role here. Now, cytokines can be a little hard to understand. A cytokine is a general word. It's not a specific item, right? It's general word. So they're proteins that are secreted by the immune system. They trigger inflammation. Histamine is a cytokine. Many of us are familiar with histamine. There are hundreds of them. Interferons, interleukins are messengers in between the immune cells. But to think about one that we can put in perspective, again, histamine is a cytokine. It causes a runny nose if we have a cold. Basically, the vessels open and leak, and therefore cells that can clear up whatever problem can squeeze through the area where normally they wouldn't be able to. That's called capillary leakage. So basically, white blood cells release the cytokines. Remember what type of white blood cells we have, like T cells, etc. And then those cytokines attract the neutrophils, and when they interact, they actually cause damage to the blood vessel linings or endothelial damage, which allows the leakage to occur. So cytokines and neutrophils together damage the cell wall, which can be a very important thing. If you have a localized injury, being able to get the macrophages and other cleanup crew through to the area is very important. Again, that's localized. The other thing that cytokines do is they regulate clotting. So cytokines can actually lead to the inactivation of protein C. Protein C devours the microclots that our body makes on a daily basis. It's out there working for us. So cytokines prevent that protein C from being in the active form. And if it's bad enough, this is able to cause DIC, which we talked about under hematology. And I said before that DIC is the worst plus one at a party. DIC never comes alone, but it is, this is why, for that it's usually associated with sepsis, is because people with sepsis are already deficient in protein C. So if we have microcirculation clots, again, that can lead to DIC, which eventually can lead to multiple organ dysfunction syndrome, or MODS, which is very deadly. There's a picture here I'd like you to see. And this basically is a visual representation about what I just talked about, the capillary permeability. So anytime we're talking about cytokines, I want you to think about leaking and clotting. So capillary leakage and clotting. The one on the left shows good integrity when your monocytes are generally inside, but the increased porosity allows the other cells that normally wouldn't get through there out. But remember, it lets not only the cells out, but also all the fluids out. So the capillaries start leaking, and then as we replace fluids, the fluid leaks out too. So this is the process behind edema and third space shifting. Okay, so the next concept to discuss in shock is systemic inflammatory response syndrome. So if you were to Google this, you will find these items, right? So these criteria. They are always the same. So SIRS is defined as 2 or more of these. So remember what bands are. They're immature neutrophils that rise in response to inflammation. So I want you to take a moment, look at SIRS, look at the SIRS criteria, and think about why these signs and symptoms might be associated with inflammation. And then we have this. So SIRS is not to be confused with sepsis, but they are very much associated. And I want to say that this is probably because of the fact that people with sepsis do tend to hang on a little bit, so we're able to see this rather than somebody who has like a massive hemorrhage, and they may not ever get to really getting into total SIRS criteria, though. Again, it's just more likely that we see it with sepsis, so doesn't mean it can't. Look on the right-hand side of the causes of SIRS: burns, pancreatitis, trauma, hemorrhage, and then other. Other is an awful lot. Could be seizures, could be lots of anything. But this is basically trying to tell us the difference between like sepsis and SIRS. And so basically, if you have a documented infection, by culture usually, so documented infection, I don't know why it's doing that, but either way, so you have a documented infection in the presence of SIRS, we call it sepsis. This is why some people you'll see admitted to the hospital with a UTI, and some people are admitted with sepsis. So this is the reason why. So to recap, there is the cause of shock, which is hypoperfusion, low oxygen and glucose, which leads to acidosis and low ATP. And the effect is the sympathetic nervous system releases adrenaline and cortisol, and then the cytokines promote inflammation. So these are both parallel, happening at the same time, but they are not the same process. And I wanted to just start to introduce you to the different types of shock. So it could be a problem with the volume or hypovolemic, a problem with the pump, so it could be cardiogenic or obstructive, or it could be circulatory or a problem with the tone. And in this are septic, neurogenic, and anaphylactic. So this is just the first section as an introduction to shock, and we will pick up in part number 2.